second globally in terms of the prevalence of hepatitis B and C after China. All viruses like A, B, C, and E, like 4 of them are quite endemic. Although the national prevalence which has been done has not shown it to be a major, it's shown that it is less than 1%. But if you look at the amount of population we have, this 1% is also a huge number. And we have launched a National Viral Hepatitis Control Program in 2018 to combat this problem. And our country is the only one after 1 or 2 that where complete diagnostic and treatment coverage is given for hepatitis B and C under this program. Now, looking at these viruses, we'll be focusing our talk only on these 5 hepatotropic viruses. All of them are RNA virus except hepatitis B. D, which is a defective, but it's still an RNA virus. Chronic infection means capable of causing long-term injury to the liver is there with B, C, and D. Slightly, the recent data is showing about E also can cause chronic infection. Capability of causing the hepatocellular carcinoma, which I told you is very, very important, is by B and C and D. And vaccine, which is available, is there with A, B, and E, but not licensed in our country. Treatment is there for hepatitis B and C, and there is a cure possible for hepatitis C virus. Now, talking about individually, since you are all microbiologists, about hepatitis B virus. Now, hepatitis B virus, we typically call it a partially double-stranded DNA virus. Why we call it a partially double-stranded? Because you can see that there is a circular genome. One strand is incomplete, and that is the positive sense, which is incomplete. The negative senses of the viruses, the strand is complete. Then it is 33.2 kb in length, belongs to the Hepatidinidae family. 4 open reading frame means 4 important proteins, and they are surface, core, polymerase, and X. So this is how they are organized. Now the whole particle, which is 42 nanometer, which has got this complete genome, the entire envelope, and all these proteins, is called as the DANE particle. However, different forms of the hepatitis B particles also in the spherical and filamentous form are also seen in circulation. All these proteins and ORFs, they form 4 important antigens I told you, and the subsequent antibodies are also formed against them. So the important antigen and for testing, for putting them treatment, are hepatitis B surface antigen and its parallel DNA by which most of the decisions are made. But I'll tell you more in detail about the genomic organization because you all are microbiology student or virology students. The positioning of these nucleotides of the viral genome is so that it is an overlapping genome structure. That means that any mutational change occurring in one region will influence the other region. That is why this is very, very important to understand in hepatitis B genome. It has got 4 mRNAs which are formed. They get converted to the proteins and the antigens are formed. Classically, you have pre-core and core protein, which forms the E antigen. Pre-genomic region forms the core and polymerase. It is the surface antigen, which has got pre-S1, S2, and S, which forms surface antigen. And then you have the X protein, which forms the X antigen of the virus. Now, mostly the infection is through non-enteral route, means that it mostly from mother to child, the infection is acquired, or the other vertical transmission or blood and body fluids, the horizontal transmission is there. Classically in hepatitis B, the infection is from mother to child. And if a neonate acquires the infection either at the time of birth or from mother to child, then 90% chance that it will land up into a chronic infection, means the body is not able to clear the virus beyond 6 months. Can be presented as simple chronic hepatitis B, but later on, as the disease progresses, the liver can land up into cirrhosis, which is initially compensated by the body, and then it may undergo decompensation, means the body cannot tolerate the cirrhotic liver and will land up into decompensation episodes and liver failure. If a hepatitis B virus is acquired in the adulthood through the horizontal, through any exposure to blood or body fluids or needle stick injury or blood transfusion, usually the immunity of the body is able to clear it within 6 months. So you may just present as asymptomatic, may land up with only acute hepatitis, but less than 1%, you may also land up into acute liver failure. Now, this is a very simple presentation which we all were taught, like acute hepatitis and chronic hepatitis B. But now the story of hepatitis B has taken another view. It is all about the host immunity and the virus capability to fight the immunity. So the fight is always happening between the virus and host immunity. And the stage of the it's a dynamic infection is decided by that who has got the upper hand. It will be more clear like this. So we do not call hepatitis B or consider hepatitis B infection as acute and chronic. It is not that simple. It is not that transparent. Oh, it's acute, it's chronic, the way we were taught. Now, the new thing is that it is a dynamic nature of infection. As I said, it's all about body's immune response. All these phases are also seen in the acute infection. Only thing is that time lapse is very, very fast and you achieve resolved infection within 6 months. Now, if the body immunity is not good or you have acquired it in the childhood, you have not formed enough amount of immune response, this will persist for years and then it becomes a chronic hepatitis B. We call it now the phase 1 when the virus enters the body. The body is tolerating, so it allows the virus to multiply. So you will see that all other markers like HPSAG, DNA, etc. are very, very high. Patient has got high viremia, has got high infection, but liver is normal because the damage to the liver in hepatitis B occurs because of the immune response. The CD8 and CD4 cells, when they are formed, they start killing the virus and removing it. That causes the damage to the liver. So this is the phase which we call at E antigen positive chronic infection, means antigen positive and it's infection only. Earlier, we used to call it tolerant. Here, mostly it is the age of 25, 20 years. If the child is acquired from the mother, that persons are actually asymptomatic because you develop symptom only when your liver is abnormal. Now, once the body's immune response start mounting, person is adult enough to form lots of immune response, they start clearing the virus. So the viral markers will come down, HPSAG level will also go down, DNA will also fluctuate or might become undetectable. But what comes is the damage to the liver, means ALT will be abnormal. This is the time when the patient usually are screened and they come to the OPD of a gastroenterologist. In the first phase, you catch them as when they donate blood, and we call them as incidentally detected hepatitis B surface antigen positive, means IDHAS. This is the phase when they usually come because of jaundice, and this and markers are positive, but you also have deranged ALT. Treatment is usually mandatory when the liver damage starts. Now, once the body's immune response is able to control the virus gets controlled. Infection doesn't go anywhere. It is silent. And that is why earlier we used to call it an inactive carrier phase. All the markers you will see has come down. Even the inflammatory activity and the ALT has been normalized. And patient may remain in this phase for years, usually 20, 30, 40 years. Now, when the second time the activation starts, it is the time when any immune suppression is happening, patient is on immunosuppressive drugs, cancer treatment, steroids, or a mutation has taken place because it's a long-standing infection. The replication rate of the virus is 10 to the power 15, so fast. And so it acquires mutation, it escapes E antigen and the replication of the virus starts, and you will have a reactivation of the hepatitis. So the markers will come again, and usually the age of the patient is 50 to 60 years when we catch them. This is a highly progressive and usually lands up into lots of fibrosis, HCC, and sometimes and many a times the death. And again, the treatment is mandatory here. Sometimes the body's immunity has a total control, the infection totally gets resolved, and then person becomes HbSAg negative. And this is known as resolved. And this is also called as, sometimes the DNA is persistent, but HbSAg is negative, and you get when you donate, sometimes you screen a donor, their DNA will be positive, HbSAg is negative. We call it as occult hepatitis B infection. I hope these phases are clear, because this is the way we normally see a patient. So no longer we are seeing them acute and chronic. Whenever a sample comes to a lab, we always teach our DM students or MD students that please try to have a longitudinal history, that which phase the patient has come to you and why these markers. So we always correlate with the ALT, we correlate with DNA, we correlate with HbSAg, and then try to see with the age that which phase the patient is looking like. So the traditional markers, which are the cornerstones, and are like this, that HbSAg is the one which is formed first. Once the good immune control is there, within 6 months, it gets cleared and gives way to the formation of antibody to core. Core antigen in the blood is never seen. It is only the antibody. First, it is IgM and then IgG, and combination is called as HB core total. Anti-HBs is usually formed 8 weeks after the HbSAg disappearance. In chronic, which we call HbSAg persists lifelong, may come down, and so that it becomes undetectable in certain cases, but it is not total absence. It only becomes very, very low. But core total will remain persistently positive. IgM is not no longer considered as a very good marker for acute, because you see that during the chronic reactivation also the IgM antibodies are formed. One thing to remember is we say that acute HBV infection, it is the virus which gets cleared from the blood. It never leaves the hepatocyte. And chronic infection, where the virus and these markers are persistent inside the blood. So, and the liver also, right? Talking about the replication, which is important to understand the markers of hepatitis B, the virus is in the relaxed circular, which I told you is the Dane particle, or it can be in the linear DNA form. The receptor to hepatocyte is NTCP, sodium taurocholate co-peptide receptors, and through which it enters. Relaxed circular, where the positive strand is incomplete, first gets completed by utilizing the polymerase and forms a triple C DNA, which is a mini chromosome. A part of the virus, which is in the form of double-stranded DNA, gets integrated into the host genome, into the host chromosome also. This triple C DNA acts as a factory and produces the DNA-dependent RNAs, 4 forms of RNA. These RNAs form proteins. These proteins, they get released. All forms of proteins are released except the core. Core is never released from the blood. So E, surface, different types of surface, they all are released. Not only this, the DNA, all forms, that is the linear DNA, circular DNA, and RNA is also released into the blood. The HBV integration, this concept is very, very new, which has recently come up, that hepatitis B gets integrated into the host genome. And this is the one which causes accelerated liver cancer, cirrhosis, and hepatitis. So now the science is moving towards that how we can prognosticate a patient by doing this integrated DNA, which can also be seen into the circulation. So there is a story of triple C DNA, which forms regular protein and releases these into the blood. And the integrated DNA is there, which lies lifelong, and it is continued to form HbSAg, as well as releases some integrated DNA into the circulation. Now, this new concept just come in a couple of years has become the basis of the newer markers for hepatitis B. So the conventional markers I told you were simple HBsAg, which tells you infection, resolving infection by antibody to HBs, E antigen, anti-E, core antibodies, and DNA. New has come is in the form of you can measure intrahepatic markers like triple C DNA and integrated DNA, which will tell you true state of burden of virus inside the liver. And the other new markers, you can should quantitate HBsAg. There are different forms of surface antigen which are there, core-related antigen and HPV RNA. So talking about each markers, hepatitis B surface antigen, as I said, is the first and very important marker for infection. It is very, very abundant. It is the most large amount of surface antigen. As I told you, it is formed by triple C DNA. It is also formed by integrated DNA. It is present as Dane particles, spherical, filamentous form. All forms are available. So it is a huge abundance. So very, very good marker. And that is why even RDTs are very good in detecting, and they have a good specificity and sensitivity since this is a very abundant marker. It tells you about you can actually see the body's, so no longer we say acute chronic, but we see the body's immune response. So immune response is good, it gets cleared very fast. Not good, it will persist for several years. All and the conventional assays which are available in the form of CLIA, ELISA, RDT can detect usually all the forms of surface antigen which is there in circulation. Once the surface antigen, the good immune response is formed, even the humoral immune response start forming and the neutralizing antibodies are formed. These neutralizing antibodies are known as antibody to surface antigen, that is NTHPS. They are also by natural infection, or if you use a recombinant part of it to develop a vaccine, then again these antibodies are formed. And once a patient starts forming these, that tells you that you are immune to the infection. They can occur as a result of exposure to the virus, or it can also occur as a result of vaccination. And adequate, and it is measured in the form of titer, more than 10, and the titers unit is milli international units, is considered to be protective. Means your body's immune response are now trained. They can persist for a long time, but sometimes they decline. So it's not necessary that if you have 1,000 titer, it will remain like this for many, many years. Anti-HPS titer, if you are vaccinated, the typical recombinant vaccine which is available in our country, it is 3-dose 016. However, newer vaccines are coming which have better adjuvants in them, and the only 2 doses are required for them. Once an adequate titer is seen, you don't have to repeat it. If you're immune competent, you have a good immunity, you don't have to do it every year. Means your body can produce the neutralizing antibodies when they get exposed to the surface antigen. So we just want to see, normally by CDC, you don't have, after vaccination, you don't have to do anti-HBs titer, but those who are at high risk, like healthcare workers, those who are sexual partners of hepatitis B infected, or newborns who are born to the mothers, there the anti-HBs titer needs to be done to show that they are responding well to the vaccination. So vaccination is giving vaccine, and immunization is measured by doing the titer. Now, what if you have not taken the complete 3 doses? Then all the 3 doses, or whatever recommended doses, they should be taken, because you may have more than 10 titer, which will look like adequate following even single dose. So initially you give a very good immune response, but that is usually not protective, or long lasting protection is not provided. So if you want a long lasting protection, all 3 doses or whatever recommended doses of a vaccine should be administered, and then you should wait for 8 weeks, and then after 2-3 months you should do a titer to understand that person's body is responding good enough or not to the vaccination. HBsAg is present and we normally do it qualitative, present or absent, but in the last decade, a quantitative test has come up. It's usually a CLIA-based assays, and they are the one by which you are calculating the amount. Now, why you want to know? Because once you put a patient on treatment, the DNA gets negative. And to prognosticate that what is happening, is the infection getting controlled? Is the immune bodies, as I showed you, that very, very rare that HbSAg on its own in an infected person will become, will seroconvert, become negative, and antibody starts forming. Only in the acute infections it is possible. Otherwise, if it is a chronic infection, a person is not never be able to acquire immunity. It may persist lifelong. So by doing HbSAg, you can quantitate HbSAg and you can see its fall or rise in a patient to prognosticate. It will actually show you that it correlates with the triple C DNA activity. We have done a couple of publications. We have shown very good results. The new assay has come up, which is HPSAG Next, which also has got very, very low limit of detection. That's the new marker which people are using as a treatment stoppage rule. Just to tell you that hepatitis B treatment, once given, is a lifelong. You just don't have to stop. But and how do we define a cure for hepatitis B? We use HbSAg value, DNA value, and ALT values to call it a cure. So a complete, which is called as a sterilizing cure, means complete cure. Very, very rare, very, very rare is when DNA is also not seen, HbSAg is also not seen, ALT have become normal, and triple C DNA from the biopsy is also shown negativity. However, mostly it is a partial cure or a functional cure. Functional cure is if DNA is below the lower limit of quantitation of any real-time PCR kit, and surface antigen also become less than the lower limit, then we call it a functional cure. Partial cure is the one which is usually observed when a patient is put on treatment, that their DNA becomes less than the lower limit of quantitation, which is usually 6 international unit, and the HbSAg has become less than 100. These are latest guidelines by which we normally tell the patient that you are partially cured from the infection. I just skipped this slide because these are the forms of HbSAg which are in circulation. There is a large form, middle length form, and a small form of hepatitis B surface antigen. It is also measured, can be measured, and usually it's correlated with the chances of causing the hepatocellular carcinoma. Core antigen and antigen appears contains this antigen. It is the antibody which we check for the infection or exposure. IgM is the first type, followed by IgG. So IgM usually appears during the exposure and disappears. But once patient, which I showed you the phase 3, the formed. IgG, normally the kits which are available cannot distinguish between IgG. Call it a total anti-HBC total, which is a marker that a person has ever got to the infection. I think I'm still audible, right? Now, correlated antigen is a new marker. Is of 3 things, that is a correlated protein, E antigen protein, and a pre-core, which it is a pre-core protein, which all these things, 3 things are released. It is very, very recent marker. Only the literature is available to evaluate, and they have shown it's very, very DNA. And this can be used to monitor a patient or at least predict chances of reactivation or HCC. So in the whole story is that whether in the inactive phase you can follow up a patient and can alarm them that something wrong is happening to your body. E antigen antibody to E. Now, E antigen, it is produced when virus is actively replicating because it is at the surface, below the surface antigen, and gets very well secreted. Its presence is usually indicates high viral load. But what happens that this also undergoes a lot of mutation. And when typical mutations at the pre-core or basal core promoter sites, these are the sites 1896 position, 11762 and 1764, which we call as pre-core and basal core promoter mutation, E antigen is either absent or negative. And in India, 60% of infection is E antigen negative, because virus is a very long-standing viral, and usually it mutates, it acquires a lot of mutation. And so you cannot tell by just doing E antigen that how patient is progressing. So E antigen and looking for antibody to E antigen are usually not done these days because of these mutations. And it can be E antigen negative hepatitis can also be there, means E antigen is negative, still patient has got very high viral DNA. And that is why HBsAg and DNA are only the cornerstone for treatment cascade. What are the molecular targets? Means what are the things that you can do in hepatitis B? As I told you, DNA is the classical marker of molecular testing, usually quantitative. Why not qualitative? Because you need to quantitate for assessment of treatment response, and quantitative assays have got good lower limit of detection, so it is usually quantitative. And you can also use DNA for genotyping the virus or checking for drug resistance, not needed routinely, but can be done. HBV RNA, which is a precursor to the DNA, can also be taken up as a good marker where you don't know that patient is responding or not. With the treatment, the DNA becomes negative, but sometimes HBV RNA in the blood persists. So it is coming up as a new marker by which you can monitor, you can prognosticate, and it can also tell you whether you can stop. So the whole debate about should we stop the treatment and HBV is coming up, and then HBV RNA is an important molecular marker. As I told you, cDNA can be done, which is reflective of sterilizing cure. Integrated DNA, only as research papers are coming up, which is very, very helpful in HCC prediction. And it's also the site for certain novel therapies which are coming up in hepatitis B. So classically, you have HBV DNA, HBV RNA as a marker by which you can do. A word about serotypes and genotypes in hepatitis B. Earlier, so surface antigen has got this major hydrophilic region where there is an A determinant region loop from 124 to 147. Now, this region of surface antigen is the highly antigenic. Against this, only the neutralizing antibodies are formed. This is the region against because of which there's differences in certain serotypic differences occur. So earlier, but now it is not done. We used to classify them into 4 serotypes with 9 subtypes as ADW, AYW, AYR, ADR. But now the and they had different geographical distribution as well as clinical significance. But now it is no longer done. We divide them into genotypes. That is upon the differences in the entire genome. If the differences in two genome is more than 8% nucleotides, then we call it a different genotype. Or in the surface region, more than 4% differences are there in the surface region, we call it a different genotype. There are 10 genotypes, A to J, and they have different geographical distribution. In India, most common is genotype D followed by A and C. We usually see D and A in India, right? So genotyping is also not done traditionally because it is not needed. You have very good drugs, and drug resistance is also done on the polymerase gene, but the treatment which is available in the form of tenofovir, that is very good, and usually genotyping or serotyping. Serotyping is not done. Genotyping is done in some treatment failure cases only. How we manage HBV? So the most of the guidelines, so the 3 important or 4 important tests are there from virology point of view, HPSAG and HPV DNA. We also look for fibrosis, and we look for ALT as a marker of hepatocellular damage. Now, if HbSAg is positive and patient is cirrhosis, you should treat the patient. And if it is not, the cirrhosis is not there, then you can look for ALT levels if they are persistently elevated, or you can look for DNA levels. More than 20,000 are usually considered for a treatment candidate. This is as per our national algorithm, and it is quite similar in other. Only recently WHO has brought about few changes, and these changes are in the form of that they have updated the guidelines that it is not only cirrhosis but even significant stage 2 fibrosis of the liver, regardless of DNA or ALT. You should consider treatment, or you should consider treatment if DNA is more than 2,000, not 20,000. If there is co-infection, family history, patient and immunosuppression, comorbidities, extrahepatic, then also you should consider giving treatment. So they have expanded the treatment coverage. Now the debate is going on that ideally you should treat all. So if HBV DNA like HCV RNA is seen, treat all, but still we are not treating all. So this virus is complete. It's quite complicated. Coming to the next important virus, it is hepatitis C. Slightly simpler because it is a single stranded RNA virus. It is the only one antigen which is important, that is core. An antibody to it is formed, which is diagnostic. So you don't have an RNA testing can be done for active infection. In terms of genotypes, there are 8 genotypes. 7 is clearly described, or 8th genotype is being published from India. And there are a lot of subtypes, and with minor variation, they are called as quasi-species. So we call it a genotype if the nucleotide similarity between two viruses is to the tune of 70%. 10 to 15%, up to 80% they're similar. It can be subtype under a genotype. And if they are just 1 to 9% differences are there, then it can be a quasi-species. So this is how we classify for HCV. Genotyping was earlier important in the era of interferon, where the treatment used to be genotype specific. Now the pan-genotypic regimes have come in the form of direct-acting antivirals. So genotyping is usually not done. It is only done in case the DA therapy, there is a failure to the treatment. Then you look for genotype of the virus to change some treatment regime, or if you're looking for a resistance-associated substitution as a cause for failure to the treatment. Unlike hepatitis B, the antibody to HCV, once formed, they remain lifelong. So how do we classify it as acute and chronic? Basis of RNA. It is the HCV replicating RNA. In 20 to 30% patients can naturally resolve the infection. So antibody keeps on occurring, but RNA is negative. And HCV RNA does not go and integrate into any chromosome inside any host cell. It is there, it replicates inside hepatocyte, but it gets cleared also. So unlike HIV and hepatitis B, HCV virus gets cleared. And if it gets cleared, that means a person has resolved the infection. This occurs in 20 to 30. 70 to 80% cases, once exposed, are not able to clear the virus, and then we call it as HCV, chronic HCV, which is that antibody is also there, but RNA is persisting beyond 6 months. Sometimes RNA may not be detectable because of fluctuation or host immune responses, but that is very rare. Usually, if a person is chronically infected, you will have antibody, and in 70 to 80%, there'll be a subsequent RNA positivity. So we test for hepatitis C infection by antibody test, which is a very good marker, tells you about ongoing infection. This antibody is not telling you about the resolving infection. This is a marker of infection. This is non-neutralizing. This is not telling that the person has acquired antibody to the antigen. It is telling you that there is an infection happening. Core antigen is a marker which is coming up, but not done, not available also. It's available as a clear platform. But RNA is the other test which tells you about ongoing infection. So anybody who's got antibody to HCV positive, do an RNA. All RNA needs to be put onto the treatment. So earlier were the test for confirmation of these in the form of immunoblot assay, but no longer done these days. We only do antibody, screen a person with the antibody and proceed with RNA and then put them onto the treatment. So antibody to HCV is a very important marker. Cascade of management for HCV is very, very simple. Just remember, do an antibody, do an RNA, and then the patient has to be put onto the treatment. This is as per the national program guidelines. The game changer is the direct acting antivirals which have come up. These are the antivirals which are all oral and they act on the viral. This is the genomic region of the virus. The names of these antivirals is on which site attacks. So if you have protease inhibitors, they are called as Previr. Previr is protease inhibitors. They act on the NS3 region of the virus. If they are acting on the NS5A region of the virus, we call them Asavirs, Daclotasvir, Edipasvir, Velpatasvir, Asavirs. If they are acting on the NS5B region, we call them Buvirs. So they are inhibiting the polymerase. So the combination of two antivirals are usually given. So most important combination is 5A with 5B or protease inhibitor with. So we have only 5A and 5B inhibitors, that is Velpatasvir, Sofosbuvir combination, which is usually given into the program in India. However, a single pill in the form of 3, which has got Buvir, Asvir, and Previr, is also available and approved in 2017, but now available in India. Simple management of HCV is very, very simple. You look for antibody, you do RNA, any RNA, put the patient on treatment. Treatment is given for 12 weeks in simple cases, 24 weeks in cirrhotic, as per the guidelines. And then you wait for the treatment to end. And then you again give a gap of 12 weeks. And then we look for an RNA clearance, and this test is called as sustained virological response, SVR12. And if this is negative, means the patient is clear of infection. So we don't do RNA monitoring when the patient is on treatment, end of treatment, 8 weeks after treatment. We give 12-week treatment, wait for 12 weeks, and then look for a sustained response. And this is how we look monitor the patient who is on treatment. Core antigen, although the WHO and guidelines say that it can be used as a test to put the initiate treatment, but you have, it is recommended by WHO guidelines, but you don't have a very good assay which is available. Genotyping, as I said, is not done, only in few cases if you have virological SVR non-attained, and then you are doing a genotyping and also doing a resistance testing in the virus. Core antigen assay is available in the form of CLIA test, has shown promising result, but again, the cost of core antigen is parallel to an HCV RNA. So now most of the labs are only doing HCV RNA in the blood. So this completes HCV. Now coming to hepatitis E virus. What has changed is the classification or taxonomy of hepatitis V virus. So Hepaviridae, but now it is orthohepiviridae and Pisla hepiviruses, in which all the human 8 genotypes of the which can cause human infection are there. Apart from it, you have hepatitis E virus present in lots of rats, ferrets, fish, etc. So it is present in extensively in so many zoonotic species. It is now E and A are the one which are through fecal-oral transmission, means they are the one when the water or food gets contaminated, you acquire hepatitis E. In a normal person, it normally causes acute sporadic viral hepatitis, like normal viral hepatitis by E. So it gets cleared. It may cause symptomatic infection, but especially in certain groups like pregnant females, it can lead to fulminant hepatic failure, ALF or ACLF, because of the hormones and the pregnancy, which enhances the replication of the virus. The new thing which has come up is the infection and immune suppressed, especially the post-transplant group, and they are by the different genotypes. So this infection, which is fulminant, is by genotype 1 and 2, but genotype 3, 4, or sometimes the rat hepatitis E virus can cause life-threatening infection and immune suppressed, and can also lead to chronic hepatitis E. So another thing about hepatitis E is its existence in the body. It is present, it usually infects hepatocytes. The virus is shed into the feces as naked HEV virion, and which is capable of causing infection. So it's a single standard RNA virus, but it has just got a capsid. However, in the blood, there is a pseudo capsule. The lipids are surrounding it, and these are known as quasi-enveloped form of HEV. Why these forms have become important? Because they allow the immune escape, the neutralization of the virus, and they are the one which are responsible for causing more lifelong and chronic infection. So this concept of the quasi-species of enveloped species of HEV is new, because of which its persistence is very, very long. Normally, the HEV infection matches peaks. So the virus comes into the blood. Viremia is first, but it is very short-lived. Then there is shedding of virus in the stool. So in the blood, quasi-forms are there. In the stool, you have the naked, which is capable of causing the infection. And they persist 1 or 2 weeks longer than in the blood. When the virus is at the peak, that is, the symptoms are also at the peak. So the antibody response in the form of IgM is also at the peak. So normally the jaundice, the peak of jaundice by peak of ALT matches with your IgM formation. And as the IgM formation starts, the virus is cleared from the blood, slightly longer in the feces, and then it is taken up by the IgG response. So IgM antibody testing is the main crux of diagnosing acute HEV infection. So in a normal person, you usually do IgM. Sometimes people do IgG, but they do dual IgG for a rise of antibody. HEV RNA is not done normally in immunocompetent. HEV RNA is done in immunocompromised because there you want to see the persistence of HEV RNA. As I said, it will persist for a long time. So presence of HEV RNA in blood or feces beyond 3 months is considered as chronic HEV infection. This is what the hepatitis E new thing has come, means in developing countries, the normal acute sporadic hepatitis is there, but in the developed countries by different genotypes, it is causing chronic infection and especially immune suppressed, which is known as autochthonous hepatitis or chronic hepatitis E by the zoonotic genotypes of the virus. It is not seen in our country. We try to look in a liver transplant that do we have this chronic infection. We have not seen, although there are a couple of case reports by PGI Chandigarh and AIMS New Delhi, where they have seen chronic persistence of HEV beyond 3 months. Another virus, hepatitis A. This virus belongs to the Picornaviridae family, hepatovirus. Again, non-enveloped, single standard, positive sense RNA virus. 6 genotypes are there. 1, 2, 3 are the human. Most commonly, genotype 1A, and India 3A is seen. Now, classically, the hepatitis A is causing acute, sporadic, or water and foodborne hepatitis in children. Now, once the children less than 6 years acquire, they usually asymptomatic and they spontaneously recover. However, if it is acquired in the adulthood, may have symptomatic but may land up into acute liver failure, but less than 1%, and can also have relapsing hepatitis or prolonged cholestasis in 10 to 20%. Just like hepatitis E, the infection can be diagnosed easily by IgM antibody because immune response start mounting, and that is the peak of the liver damage. So the ALT rise can be easily tested by IgM antibody response in the blood. So it's a very simple test to do. What is changing is that we have also published it is that we are seeing declining. So once you are exposed to hepatitis A, you form IgG and they give you a lifelong protection. This kind of IgG are neutralizing. But earlier, it used to be seen in more than 95% of the people, but now we are seeing a declining HAV IgG levels in the adults. And that is why once they acquire infection in their adolescent or adult age group, they land up into severe form of liver hepatitis, usually as ALF and ACLF. Hospitalization is also coming up in a high way, and severe hepatitis is coming up. So catch-up vaccination for hepatitis A is needed. If you have not, now this is typically because there are two type of population, one who are drinking very clean water, so no exposure, and those who have getting exposure, frequent exposure to this hepatitis A, and they can transmit infection to them. And that is why we are seeing a sudden surge in hepatitis A related jaundice and ALF or fulminant hepatitis in adult and adolescent age group, especially in the urban setup. Hepatitis delta virus is a defective virus. It requires hepatitis B surface virus for its replication. Without it, it cannot. But as we were discussing earlier, sometimes its screening becomes imperative in case you cannot explain the unexplained jaundice or unexplained liver damage despite negativity for hepatitis B, then you can screen and there may be low level of HPSAG. Two types of infection when delta virus causes and hepatitis B together they cause. Usually the recovery occurs, but fulminant hepatitis. Now, important is that there is a chronic hepatitis B on which an acute superinfection. Here, there is a rapid progression of severe disease and towards a liver failure, which will be seen in this case. How we look for this infection? There are specific IgM and IgG tests. IgM will tell you recent, IgG will tell you chronic, and by which you can do the testing. HTV RNA is always required to be done for confirmation of an ongoing viremia for hepatitis delta virus. In India, however, we are not seeing a lot of delta virus infection. These are studies in the last 2 decades. We have also done one study where the prevalence has been found less than 1%. So sometimes 0, 10 testing is seen. Recently, all the association like PN, Asia Pacific, as well as WHO, they have this infection or those which are associated with fulminant liver damage or hepatocellular carcinoma. So they have in their guidelines now, they are incorporated that one should also screen hepatitis delta virus either by antibody and this is the target population which all these guidelines. So WHO says that all those who are HPSAG positive should be for anti-HTV antibodies, IgM, IgG, as well as HTV RNA. And this should be lab-based reflex. Means anybody who is coming out HBsAg positive, immediately put on anti-HTV test. In endemic countries, HBV DNA is there and there is high ALT levels or high risk group not seeing a high DNA, go ahead and do latest guidelines. The WHO has come up with 2 new concepts, reflex testing, which I really want to share with you. Lab-based means that you got a blood sample and this can be for B, C or HTV and you found it positive. From automatically do a viral load test and so that the patient's report can be immediately released and if the patient requires treatment, immediately put on to the treatment. This is known as sample on do. Clinic-based reflex testing is a strategy which involves single clinic visit. So you can do a rapid card test in the clinic. You can see the patient is positive. You can do it with RDT. And in the clinic only, you collect the venous blood and then send it to the lab for a viral load testing. So these concept of reflex viral load testing is emphasizing that all the labs, if any serological B, C, D is simultaneously look for the viral load. So I end my talk by summarizing that viral hepatitis testing spectrum is actually changing, moving towards lots of molecular diagnostics. The innovations have come up in HBV, HCV testing and monitoring guidelines. WHO and A and E epidemiology is changing. As I showed you, E is coming up with chronic infection, A is coming with fulminant infection. I think the lab people should be updated with all the markers and other recent guidelines. So I thank you all. I hope and I encourage all the students to get started. Thank you.
Thank you, Dr. Ekta. I'm sure this was very useful for all the PGs. It was a great session. I also learned a lot of things. And there are a few questions. One is anti-HBs titer also same for healthcare workers?
For healthcare workers, initially a decade back, there were studies which have come up that more means tight is in a very, if you're especially working on very highly, infectious population, but I think now it is more than 10, which is good enough.
Okay. The
Those
other
were
is
very
other question is titer to be checked after complete 3 doses. If yes, then after how many months of all 3 doses?
I told you, after 2 to 3 months, means 8 weeks, more than 8 weeks. Yeah. Because that is a good time that your body will develop, mount a very good immune. So sometimes what happens when you are exposed to in some patient, you have a hyperimmune response. Immediately, you will get a very good anti-HBs. But that is not lifelong and good protection. The studies have shown. So you should give complete dose of vaccine 016, or you are on a 2-dose Hepislav. So it is 1 and 2 01. Wait for 8 weeks, good immune response, and then check for a titer. If that is more than 10, that is adequate, then nothing else to be done.
All right. Then there is, I think, one more question that someone is asking that I'm fully immunized 15 years back and now my titers are low. So should they start from the first dose of booster dose? I think what she means is that should she repeat all three or just
No,
take a booster?
see, that is what we are saying. Vaccination is 016. So if you remember clearly that I have taken, or you have a documented proof that you have taken 3 doses of vaccine, after that, you are immunocompetent, you are a normal person, there is no need to do an anti-HBs. But an anti-HBs is needed if you are either high risk, needs to be done after 8 weeks. If you have a documented proof that you developed an immune response to the vaccine, then you don't have to repeat the titer or do anything. You just have to carry that documented report that yes, I have received 3 doses and my body is sufficient enough to mount an immune response, right? So in that, there is no need for a booster if you are totally immunocompetent. Sometimes if you have an exposure, sudden exposure, then to allay the anxiety, we give a vaccine booster, or you are planning to go on an immunosuppressive treatment, some steroid treatment, then again, after evaluation by the physician, you may be put on to, they may give immunocompetent person. You
All
don't
right.
have to repeat your vaccination
Maybe.
after 15 years.
Okay. What is core window? That's another. And is there a sexual transmission for HIV? These are the two questions.
What is it? Reverse.
What is
So
core
window
window?
period, core window. So
Hmm.
window period is infection. So it can be your serology window period or it can be a PCR window period. Core window window for hepatitis B, if you're asking, core antigen is never picked up. It is the IgM antibody, which we antibody.
I think
Maybe the
I think what they mean is that the window during which there will be no antigen or no antibody detectable, a very small part.
what the window when
Will-
I can't hear you, Dr. Sonal, maybe. Yeah.
I think I also lost you for some time.
Okay.
Mm.
Am I audible now?
Yeah, you're audible, but your voice was cracking in between. What I'm asking is that is the core window same as the period during which there is no antigen or antibody detectable? Do they mean by that as core window? Please explain yourself. I'm asking the person who's posted this question, not you,
We
Ekta.
call it a serological, can you hear me?
Yeah,
Window
yeah.
or
No, we lost you, Ekta.
a PCR first to come. So surface will come. We are not dependent upon core IgM for diagnosing infection. So you don't have a window period for core IgM and in hepatitis B, right? So it is, I think, period where you have the surface antigen is not formed, so that, and they can be DNA in that, and that is why in blood banks we encourage screening high endemic area by NAT testing by PCR. Yeah.
Okay. The other question is there any sexual transmission for HAV?
The viremia, see, anything, if there is viremia, the remotest possibilities can be there, but that viremia is very weak and there is acute jaundice at that time. Theoretically possible, otherwise not documented at all.
Ma'am, kindly
Not
explain the
sexual
disappearance
transmission.
of HBs antigen in 6 months in AHB.
I told you in this Z. So I said that acute teaching method, when it used to be that hepatitis B surface antigen from blood disappears within 6 months, body's immune response clears it. So HbsAg is start forming. Uh,
Okay. Now, this one I think you've already answered. Is there any scenario where HBe antigen is positive in the absence
I
of
can,
HBV DNA?
yeah, can you repeat it, Dr. Son?
Yeah. Scenario where HBe antigen may be positive in the absence of HBV DNA.
Antigen. HB antigen is positive in the absence of
Yeah,
DNA.
HBV DNA is not there, but HBe antigen is positive. Because
That
yeah,
happens.
that will happen because it just shows
Suppose
replication.
when you're giving a treatment, tenofovir and this edifovir is acting on becomes negative. So this scenario is usually seen when the hepatitis B infection is transmitted from mother to child. What happens is when you're transferring the infection, the surface antigen and E antigen acts as a tolerogen. I did not speak about the newborns or immune system fails to recognize it as an antigen, and they don't never mount an immune response because it is acquired. They become antigen is also called as a telogen. So a person will never be able to mount an antibody response to the E antigen. Surface antigen, E antigen remains persistently positive. DNA may get cleared by giving an antiviral or but E antigen is persistently. So there are such cases, a lot of such cases where they are persistently E antigen positive.
Chalo, I think we'll call it a day here. Thank you so much. We prolonged your day at ILBS today. Thank you so much. I think it was very informative and a lot of doubts got cleared. And Many compliments to you, Ekta, as usual. They're doing very good work and taking a very good class. Thank you so much. Thank you, everybody, for
Thank you,
joining
Dr.
in.
Pleasure was- Yeah, thank you.
Ciao.